In the history, we saw a typical point that the patient had developed bleeding soon after the procedure. So it was the endoscopic stenting which has caused bleeding in a case of obstructive jaundice. So that brings us to one important entity called as coagulopathy. Why is there a disturbance of coagulation in this obstructive jaundice patient? It is because there are multiple reasons. The main important reasons is that there is impaired vitamin K absorption from the gut, and that is due to the secondary to lack of intestinal bile because of obstruction. So there is deficiency of vitamin K and its dependent clotting factors like 2, 7, 9, 10, and that is causing a disturbance in coagulation, and that will be manifested as a prolonged prothrombin time. Prolonged PT is going to get elevated, prothrombin time is going to get elevated, and that is the reason the patient is having a coagulopathy, and also because of the endotoxemia, that is the gut intestinal barrier is not maintained in obstructive jaundice. So because of that, the gram negative bacteria which enters the bloodstream, which is nothing but the lipopolysaccharides of the gram negative bacteria, that will affect the metabolism of factors like factors 11 and factor 12, that is responsible for the platelet and direct endothelial damage. So these are all affected in obstructive jaundice. So you might very well ask me how to remember that in deficiency of vitamin K affecting vitamin K dependent clotting factors causes prolonged in prothrombin time. Why not APTT? What is, in other words, what is prothrombin time? What is APTT? So there are two pathways called as extrinsic pathway of coagulation and intrinsic pathway of coagulation. A small rewind to your pathology where the pathways of coagulation are two, namely extrinsic pathway and intrinsic pathway, and that will lead on to what is called as a common pathway. Now what happens is the factor 12 gets activated into 12A, and activated 12A causes activation of 11 into 11A, which in turn causes activation of factor 9 into 9A, and thereby and also 8 will activated 8 also will act in all this intrinsic pathway, and when all this occurs, the extrinsic pathway, namely the tissue factor from the damaged tissue will activate factor 7. Remember, number 7 is the only factor here which will play an activation of 10 to 10A. This is a common pathway until here extrinsic is separate, intrinsic is separate. Then comes the common pathway where 10 is activated into 10A, and this 10A is responsible for the conversion of prothrombin into thrombin, which stabilizes the fibrinogen into fibrin. So these are all responsible for the coagulation mechanisms in obstructive jaundice. Now you might very well ask me, sir, what happens, how to remember prothrombin time gets deranged? See, in any pathway, including the extrinsic pathway, you have derangements of prothrombin time, PT, whereas in intrinsic pathway, you have derangement of APTT, activated partial thromboplastin time. That is a disorder of intrinsic pathway. This is a disorder of intrinsic pathway. And how to remember that? Prothrombin time has single T. Remember, tennis has single T. Tennis is played outdoor, and thereby that is leading to an extrinsic pathway. So PT is one which is responsible for extrinsic pathway. So extrinsic pathway factors like 7 and all that, which are vitamin K dependent, that is lead to derangement in prothrombin time. If you take a prothrombin time and INR, that is what we do in obstructive jaundice. It might be deranged, leading to a clue that this is coagulopathy, underlying coagulopathy due to obstructive jaundice. Whereas in any pathways of the intrinsic pathway, there is going to be derangement in APTT. APTT has double T, that is table tennis has double T. TT, table tennis, is played indoor, and thereby intrinsic pathway derangements will lead to alteration in APTT pathway. So what are you going to deal with? How are you going to? So we have a patient who have derangements of all this. So how to treat the coagulopathy for these patients? You treat the expected coagulopathy prior to any intervention. You start on vitamin K. 10 mg IV and repeat if required. FFP 15 ml per kg per body weight if vitamin K is resistant, and if INR greater than 1.5, consider biliary drainage in the form of stenting or percutaneous transhepatic biliary drainage. If coagulopathy is due to underlying liver diseases, then you have to refer to hepatology unit. If it is due to anticoagulant usage, refer to hematology, but have an overall view in mind that if underlying coagulopathy in the form of deranged prothrombin time and INR, then you have to give vitamin K 10 mg continuous in IV and repeat if required, and you might very well treat with FFP by giving 15 ml per kg body weight. If vitamin K resistant, then you have to give FFP. Suppose if the INR is greater than 1.5, then you have to consider biliary drainage. All these are treatment of underlying coagulopathy. So this is how you deal with patients who present with underlying coagulopathy in obstructive jaundice. Also, this carries an important message that how you have to settle a patient before taking in for surgery. So I already said that what is the reason for loss of weight in pancreatic cancer patients? In pancreatic cancer patients or all those etiology, malignant etiologies, there is going to be obstructive jaundice, which itself cause anorexia. Also, there might be malnutrition due to exocrine insufficiency because of the loss of enzymes, and there is going to be cancer cachexia. And I already said that 2% significant loss of weight in 1 week, 5% in 1 month, 7.5% in 3 months, 10% in 6 months are all significant factors which are called a significant loss of weight. Now, coming to the cancer cachexia, I said what is cancer cachexia? There is a definition by Fearon. Fearon defines cancer cachexia as loss of skeletal muscle mass with loss of fat mass, which cannot be fully reversed by conventional nutritional support, and that will lead to progressive functional impairment. That is called as cancer cachexia. There is a definition, criteria, management of it, and there is a staging called as pre-cachexia, cachexia, refractory cachexia. No need to go into depth into that.